Hello there. Good. I can't hear you.
Oops, good afternoon.
Oh, there we go. So sorry that I'm running behind. I've got literally two other classes that I'm trying to teach today. But um, we will get going here shortly, and we'll see how many folks show up. Um, and actually, let's see here. Make sure that I've got everybody. Yeah. Perfect. Okay. Um, it might just be us three, but if that's the case, then that's okay. So just so you know, I I do apologize for having to kind of reschedule a couple of times now. We've kind of been through the ringer a bit as a family. Um, this past this past week or last week, I was sick with some sort of stomach bug. Everybody in the family, including our kids, had it. Then I have and had, and I'm getting over pink eye this past week. First time ever in my entire life I've ever had pink eye. In addition to that, today is my kid's birthday, and I'm doing the best I can to offer these classes, knowing that you guys need this time, but just trying to let you know what I'm also giving up on my end. Um, on top of that, I've got to go. I was told yesterday that I'm going to St. Louis, Missouri to testify in court for Monday. I've got to leave tomorrow. So it's
Oh
been a
wow.
it's been a week. Um, I'm telling you all that not to make you feel, sad for me or anything, but to let you know that I really am doing the best I can to offer as much as I possibly can for an online course that at times can be a challenge to get uh, a schedule down on the weekend that makes sense for everybody. Um, because with online courses, unfortunately, I don't have the option of offering these like on a weeknight because some of y'all are taking weeknight courses, and I don't know what days are open and what days aren't for everybody, unfortunately. And so I have to try to do the weekends, and then the weekends just ends up being a little bit harder to do at times. With all that said, though, today we are going to cover quite a bit, and my goal is to get us through um, neurodevelopmental disorders, schizophrenia, and the psychotic disorders, bipolar, and depression. And I'm going to shoot for us wrapping up around, I would say about 12:30, because I have another class after you guys, and we all need to eat, and I will need to eat lunch probably about 12:30. So, does that sound good for everybody? I'm gonna
Sounds
assume
good
it
to me.
sounds great. And it'll probably be a little bit quicker too if it's only us four. But since it's only us four, y'all please feel free to ask any questions that you want. And if I can help with exam questions or Quiz questions. What we'll do is I will pause the recording and give you all the benefit of my assistance for those who aren't here. I'm sorry. Won't pause the recording, but I will give you the opportunity to ask me questions in relation to the quizzes and exams. Where if you're not here today, obviously you don't get that benefit, but they'll still be able to watch the recording. So, wish I could reward y'all better than that, but everybody has stuff going on, especially this weekend. So I'm going to share my screen and we're going to get us going here. Anybody have questions about anything just, like technical before we jump into the content? All right. So starting with our week 1 PowerPoint slides and going from there, I'm going to walk us through a brief review of some of the brain stuff, quickly jump in and talk about neurodevelopmental disorders and ADHD. We're actually going to talk quite a bit about ADHD. And then we'll talk about depression, bipolar, schizophrenia, and psychosis. So let's do this. Sorry, I'm trying to get this to share real quick. There we go. All right. This would be like a crash course, except we're not going to crash. We are going to arrive safely. All right. First things first, you need to know some stuff about the brain. This is important stuff. One is that, remember, and if you don't remember anything else in this whole class, remember this. The brain is plastic, meaning that it is constantly changing, growing new connections, perhaps even replacing some neurons, brain cells, throughout one's entire life. But it doesn't fully develop. Really, what that means is the frontal lobe, which is what controls the vast majority of the brain, the frontal lobe does not fully develop or have all of its connections strengthened to an adult level until about age 20 to 25. What that means is all of the functions of the frontal lobe aren't adult-like in their development until about 20 or 25. Okay? Whereas the rest of the brain will have adult-like abilities or the capacity for adult-like functioning before that. Now, what does the frontal lobe do? As it relates to this class, the most important thing is, one, it is where we get emotional regulation and the ability to put the brakes on emotional reactions. Okay? So in other words, if you're driving down the road and somebody like cuts you off, that might make you emotionally angry or upset, but you don't allow those emotions to control your behavior in that situation. And the reason why you don't do that is because your frontal lobe says, hey, it's not worth it ruining my day or life by getting mad and having road rage with this person. That's your frontal lobe. That's what the frontal lobe does. Another thing that the frontal lobe does as it relates to this class, which is important, is personality. So personality traits and characteristics like social skills, social judgment, extroversion, introversion, um, moral judgment, self-awareness, empathy, mental flexibility, behavioral flexibility, all that stuff is what the frontal lobe does. All right, next topic. Your brain does what's called top-down and bottom-up processing. I think I said it last time, or the last class we had, but I'll just a refresher. The further up you go in the brain, in other words, the outside of the brain, the more complex of a function that is localized there. So if I asked you, for example, 2x plus 5 equals 15, and what does x equal? I'm not going to really ask you that question, don't worry. Your ability to solve that equation comes from your cortex, the outside of your brain. It's gray matter. Doesn't come from your brainstem, doesn't come from your cerebellum or your midbrain. It comes from the cortex, the outside of the brain. But your ability to breathe and regulate your blood pressure and to be awake even and alert while you're solving that algebraic equation comes from your brainstem. Now, obviously, if you didn't have a brainstem, you couldn't do algebra, right? You wouldn't be able to breathe. If you can't breathe, you can't do algebra. It's just logic. The same holds true is that you also couldn't, you wouldn't be able to do that algebra, or I'll say this, you wouldn't be able to breathe if you didn't have something that was suppressing your brainstem's drive to make you prioritize just breathing over everything else, right? Because the brainstem just wants you to breathe, doesn't want you to do any algebra. Like for example, if you were, if I ask you to hold your breath, and if you decide to do it right now, please don't pass out. But you can hold your breath for a really long time. And for sometimes, some people can hold their breath so long that they cause themselves to pass out. Well, that is a perfect example of top-down processing where your cortex, the outside of your brain, is taking over control over a lower function. It's telling the brainstem, like, I don't care what you say, brainstem, I'm going to hold my breath. Eventually, and thankfully, the brainstem wins that battle. That's why you pass out, by the way. If you hold your breath until you pass out, it's literally because your brainstem has said, you know what? I don't trust you anymore driving. It's time for you to start breathing again. Because if you don't, you're not going to live very much longer. So the brainstem will override that. But you can override the brainstem by holding your breath. The same is also true for your emotions. You can override your emotional drive, what your emotions are compelling you to do, by using your cortex up to a point. So for example, if you are well, let's say this. there comes a point where if you were, let's say, a soldier in the army, that you would be able to overcome and override the fight or flight response that would be happening to a point. Because at some point, it might be such a traumatic experience that the fight or flight response has to kick back in order to keep you safe. We'll talk a lot about that when we get eventually to talking about PTSD. But in other words, there is a bottom up and a top down kind of tug of war always going on. And the idea is that we want a balance between it all. That's really a good way of looking at it. We want a balance between the bottom up and top down processing. Okay. All right. And keep moving us forward. You need to know what the amygdala and the hippocampus is. The amygdala is literally an almond-shaped little bunch of neurons inside the brain. It looks like it's on the outside here, but it's not. So if you actually looked inside the outside of the brain, you would see, and it's not this colorful, but you would see a little area that looks like a little tiny seahorse, and it looks like that seahorse is connected next to a little tiny almond. And that's the amygdala and the hippocampus. If you've ever seen Inside Out, the cartoon, you can associate, and this is the most accurate way of looking at it, associate the character, the emotion fear in Riley's head with the amygdala. That's what the amygdala is. Your amygdala, since day one, has been taking all the information that is coming in your eyeballs and your ears, everything, all your sensory perception, analyzing it, trying to find something that's potentially dangerous. Because if it is, it's going to tell the hippocampus, hey, remember this. And two, it's going to be crucial in starting the fight or flight response that may ultimately help you survive. Okay? With the amygdala goes the hippocampus. And just remember the hippocampus, you can think about it this way. I always kind of laugh. It's like elephants never forget, but hippos always go to school. That's how I've always remembered what the hippocampus does, meaning that the hippocampus is what consolidates experiences into long-term memory. So it's not where long-term memory is stored, by the way. Long-term memory is stored all throughout the brain. So if you think about like chickens, there's a pathway in your brain that's outside of the hippocampus. That's the chicken pathway. If you think about math, there's a pathway for long-term memory for everything that you remember for math. That's not the hippocampus. But what the hippocampus does, though, is it receives information from the amygdala. The amygdala says, hey, this is 8 out of 10 important memory, or this is 2 out of 10, not all that important. Takes all that information and says, okay, well, this is 8 out of 10 important, so let's put it here in the brain. That's a pathway we use pretty frequently. So we need to remember that. Or we don't ever really use this, what I had for breakfast 2 weeks ago. I don't really need to know that for the long haul. Maybe there's some reason why I might need to know it. And so let's put it over here in this other pathway that never gets used. Okay? That's what the hippocampus does. most, well, I'll say this. You've got two hippocampi. You've got two amygdalas. You got a left and a right temporal or left and right lobe or hemispheres, and in each hemisphere you have a hippocampus and an amygdala. For the most part, in the left hemisphere, the left amygdala and left hippocampus, they deal with the autobiographical memories, like it's the memory that says, I, me, as a person, remember my grandma making uh, brownies, like Reese's peanut butter cup brownies one time. That's an autobiographical memory that I could write down with words, right? It's called explicit memory. That I'm able to do that because my left amygdala and my left hippocampus are functioning. And were functioning at the time that that memory was formed. On the other side, though, my right amygdala and right hippocampus also remembers that memory, but there's no way to verbally express that memory from a right hemisphere standpoint because it's just an intuitive feeling, or it might be an implicit recognition. There's something in my brain that whenever I take a bite of Reese's peanut butter cup brownies now, that my heart rate goes down a little bit and I feel a little bit more relaxed, not because of the brownie, but literally because my right hemisphere remembers that and has associated brownies with being at my grandma's house or whatever. Okay. So that's the difference between the left and the right hemispheres in relation to how memories and long-term, short-term memories can trigger subjective experiences. Okay. All right. This is crash coursing, but we'll get there. Let's talk about neurotransmitters. So we'll catch y'all up there. What are neurotransmitters? Well, each brain cell in your brain, each neuron is an island. It's by itself. It is not physically connected with anything. Well, that's good in some ways because it's not physically connected with anything means that it can produce a system that's a lot more plastic or responsive, and that's why our brain's able to like make new connections and to change and modify itself so well and so quickly. But in order for it to do that, it has to communicate with neighboring neurons and connections, and it uses chemicals to do that, which are called neurotransmitters. So when we talk about like psychiatric medication in this class, you need to understand most of those psychiatric medications, what they're doing is they are either modifying the brain cells themselves and how much of a neurotransmitter they're letting out when they send messages, or how much of a neurotransmitter they're receiving. They're modifying that, either increasing or decreasing it, or they're directly increasing how much neurotransmitter is present. So you can either manipulate how much, I'm sorry, not either. You can either and or manipulate how much a neuron can receive, how much neurotransmitter a neuron can receive in a message, or how much it can send in a message, or how much of that neurotransmitter exists in the to begin with. And most of the psychiatric medications, that's what they do. They kind of do both. They usually increase how much neurotransmitter or decrease how much neurotransmitter there is, which then in turn modifies how well those neurons receive and use it in communication. Okay. All right. If you think about it this way, a neuron talking to another neuron is like it's like a telephone, right? You remember a telephone when you were a little kid? You had like little cups. You put the string, put the two cups together. You talk. One person would talk on one end. The other person put it up to their ear. All right. Imagine that is two neurons, right? And imagine that connection, that string, is uh, is real. Just for a second, even though I just told you they're not really connected, but just hang on just a second. So imagine that string is real, but in order for this brain cell, this neuron, to talk to this one, we need the message to go from one side to the other, right? So, in other words, we need it to be, since it's an electrochemical process that happens, we need that to be excitable. We need it to be an electrical charge, in other words, right? So, what that means is that there are some neurotransmitters that can facilitate that and be more likely for this side to send an electrical signal to the other side. And those are called excitatory neurotransmitters. So if I said, what does an excitatory neurotransmitter do? Your answer would be, well, it helps neurons, or it increases the probability that one neuron is going to send a message to another neuron. That's the best way of describing it. It increases the charge, so to speak. That neuron is more likely to shock the other neuron because of it. That's a terrible way of describing it, but it makes sense kind of at a fundamental level. There are also neurons that are inhibitory. So there's excitatory, which is most likely to keep a message going between two neurons. And there are neurotransmitters that are less likely, or they're likely to stop or slow down that message. Those are called inhibitory. Okay. Then you have, just to make it more complicated, you have modulatory neurotransmitters. And these are neurotransmitters that, depending on where you're talking about in the brain, it might be excitatory or it might be inhibitory. Okay. When I say excitatory, it doesn't mean like making it excited. It literally just means that it's more likely for that neuron to continue firing a message. This is where it's also, that principle gets confused when people talk about ADHD medication. People always wonder, it's like, well, why would I want to give a kid who is hyperactive and impulsive stimulant? Why would you want to stimulate them? Seems like they're too stimulated, right? Well, you need the frontal lobe to be stimulated in order for it to work as a brake pedal, right? The brakes on your car stop your car. They slow your car down. If you don't have the electrical wiring working, if the electrical circuit is not excited electrically, your brakes will not work. That's the same concept that we're talking about these neurotransmitters, is that excitatory doesn't necessarily mean they make you or give you energy. Sometimes it does, but other times, if you've got too much, for example, if you've got too much norepinephrine kind of flooding the system, it's going to make you tired. In fact, that's the number one most common complaint for people who just start taking serotonin norepinephrine reuptake inhibitors. When you boost norepinephrine real fast, it makes people sleepy, even though it's an excitatory neurotransmitter. Or some kids, whenever they're dosed either too high or too low, or they've got the wrong diagnosis to begin with of ADHD, and they treat them with a stimulant, a lot of times this is where we get the zombies from. Okay? All right. Reason why you need to know about all these neurotransmitters is because there are aspects of, hang on, having too much or too little of these that can relate to different symptoms, which can then in turn relate to different diagnoses. For example, if you've, and this is all theoretical, it's a lot more complicated than this. And if you really want to get into the deep dive on that, there's a ton of research coming out that's kind of, it basically at the end of the day just tells us that all of our concepts and theories of how the brain works as it relates to these neurotransmitters is a lot more complicated than what we give it credit for. But to make it simple and something that does work clinically, it helps to think about it this way. For example, dopamine, if you don't have enough dopamine, you're likely to be depressed. If you have too much dopamine, you're likely to be paranoid and psychotic and anxious. Okay? If you don't have enough serotonin, you're likely to be anxious and depressed, worried, have trouble with intrusive thoughts. Okay? If you have too much serotonin, you will be asleep, apathetic, flat. Okay? And so, even though these are oversimplifications, you need to kind of know that this is the bases from which the DSM-5 has been built, where the idea is that in psychiatry, they manipulate the amount of these neurotransmitters with the hope that by doing so, we can improve things like depression or anxiety or paranoia, psychosis, so forth. Okay. All right. Let's talk about neurodevelopmental disorders. And I realize that we are flying, but that's all right because we're going to cover a lot of good information. All right. So in the DSM-5, you've got the neurodevelopmental disorders section. And who can tell me real quick why would we include a diagnosis there versus like, let's say in depressive disorders or PTSD? Why would that, what's the whole point of even having that section? Everybody's like, it's Saturday. Just be glad I'm here, Dr. Armstrong. All right. Don't feel like you have to answer. I'll answer for you. The reason why we have neurodevelopmental disorder section is because everything in that section is supposed to have begun or started or had an onset during sometime between conception and age 20 to 25 when the frontal lobe wraps up its full development. That's the neurodevelopmental time frame. So if it happens after that or has an onset after that, it's not a neurodevelopmental disorder. Some of you might ask, well, what about depression? Depression can have an onset during childhood. That's true, but it isn't directly affecting neurodevelopment, though. So, in other words, neurodevelopmental disorders are disorders of development. You can have depression and anxiety and things like that have an onset during development, but ADHD, autism, those are disorders of development. And you can't have a disorder of development if you're no longer developing. That's why we have neurodevelopmental disorders. All right. With that said, we've got the DSM-5, and I'm going to spend quite a bit of time on ADHD in adults because it's a really big thing right now, and there's a lot of misinformation out there. But we will also talk about IDD, intellectual disorders, and autism and learning disorders, but not nearly as much as the ADHD side of stuff. ADHD in adulthood, and I get this question a lot, is adult onset ADHD, is it a real thing? Well, let's first figure out what ADHD is. And if we can do that, we can probably answer our own question there. ADHD, get there, classically defined by the DSM, by the American Psychiatric Association, used to be called two different diagnoses, which is what? ADD and ADHD. I still get patients pretty frequently that come in that will say, "Oh yeah, I'm here for ADD testing," or if I mention, I'll say, "Yeah, so we'll be able to rule out ADHD," and they'll ask me, "Well, what about ADD? Are you going to also test for that?" It's because they're unaware that ADD is no longer a thing, not since 2013. But now we've got three different types of ADHD, where there is the inattentive presentation, there's the hyperactive impulsive type, and there's the combined type. So what is it? Well, ADHD is a disorder that affects one's ability to sustain attention for extended periods of time, to filter distractions, to inhibit impulses, and to regulate just general self-regulation. Now, that's the classical definition of it. What I would encourage you to note is that ADHD is probably better described as an executive functioning disorder, which includes all the things that I just said, but also it includes like higher order stuff like taking initiative, sustaining motivation when there's not an immediate reward available, self-monitoring while completing tasks, being aware of what you're doing when you're doing it, while you're doing it. It is task monitoring, the quality of behavior that you're completing. But it also includes things like social skills, social judgment, moral judgment, mental flexibility, creative problem solving. It is the ability to stop trying to make something work that's not working. That's what ADHD affects. All of those things. It affects the frontal lobe, which includes all those functions, which means that it's so much more than just an attention problem. To say something's like ADD, oh, you're ADD, you can't pay attention. Well, that's about 1% of what ADHD actually is. ADHD is an executive functioning disorder And here's the thing, everything I listed out, by the way, first of all, it's not all of it. But secondly, not everybody with ADHD is going to have impaired or problems with all of those areas. Some people with ADHD are really good at some of those areas. But what's common with everybody with ADHD is that since childhood, they have had at least some degree of executive dysfunction in one or more of those domains as compared to their peers. And here's the important piece, it has affected them functionally and reduced their overall quality of life. In other words, if I were, let's say that I've got an ADHD brain, and I do, I've got the neurology of ADHD or the pathophysiology happening no matter where I go. I go to the moon, I still have ADHD, a brain. If I become a billionaire, better believe I will be buying myself an island and a bed, beach bed, where my only responsibility will be to wake up and roll over and out of one eye, watch the waves roll in. And even though I've got an ADHD, the neurology, pathophysiology brain still on that island, I will not be diagnosed with ADHD on that island because it's not affecting me functionally. The next question that might imply, and you're probably asking yourself, well, how do we know, well, what's the line? How much disruption to daily functioning should it cause before we make a diagnosis? Well, the answer to that is it's arbitrary, but technically defined by the DSM-5. And it is arbitrary. The question is, well, how much dysfunction has to be present in order for us to make a diagnosis? It's really arbitrary because they just kind of made that up. It's a threshold of saying, well, up to this point, the symptoms can cause this much dysfunction, but if you cross this threshold here, now you have a diagnosis. Now it needs to be treated, and it's arbitrary. The other thing is that you can't just say it causes you dysfunction because it might be that the system in which that person's brain is trying to function, the system itself is broken, which is true. So the reality is that probably we have seen an increase in the number of people being diagnosed with ADHD, at least in part because we live in a society in the world that is not very, it's not shaped for how our brain wants to function. Our brain isn't designed to work 40 hours a week. It's not. Our brain isn't designed to stay up much later past when the sun goes down. Brain isn't designed for homework. Kids are not. Their brains, it's like the opposite of biology for homework to happen at night anyway. So there's many things about our society that aren't in line with what we know about the brain, and we're trying to force our brain's biology to fit into systems that are broken. And so, yeah, for some people, their brain may not fit very well into that system, which causes a level of dysfunction, or could be labeled as dysfunction enough, so much so that could qualify for ADHD. So there is a subjective side to this piece, or this whole diagnosis, including not just ADHD, but all of them. With all that said, ADHD is often a, a final diagnosis that you land on after kind of ruling everything else out. Meaning, if you have enough anxiety, it can, for a long enough period of time, it can look like ADHD. If you get depression that's severe enough, it can absolutely interfere with attention span and executive functioning to the point that it would look identical to ADHD. Or probably the thing that I see a lot is obstructive sleep apnea, where it by itself can cause attention problems, processing speed problems, decreased mood, executive functioning problems, all of those things, and ultimately be one of the most common uh, ADHD mimics in adulthood. All right. So I get a lot of people asking questions of like, what causes ADHD specifically? And on average, you got to look at it this way, is that there is a spectrum of what can cause ADHD for any one individual. But on average, it's about 60 to 70% genetics, 30% environment. What that means genetically is that there are genes that are passed on that have the ability to modify the dopamine neurotransmitter system in the brain. Doesn't mean that they will modify that system. It's just that they have the capacity to, and to have that capacity is the underlying genetic risk. That's the potential. Once you couple that potential, the genetic potential, with something that's triggering for it in the environment, that's the environment side, genetics plus environment in that situation is how you arrive at developing ADHD. To make it a little bit more complicated, you can also have zero family history of ADHD, no genetic predisposition, and have enough environmental input to cause the brain to develop ADHD. For example, most kiddos and most adults who have a prenatal or complicated prenatal history, let's say they were exposed to like alcohol or cannabis or methamphetamine or even nicotine, if they have that as their background, that might be enough in some cases, even though they don't have any genetic predisposition for it or risk for it. It might be enough in some cases for them to develop ADHD. Or a kid might have a brain injury, let's say at age 4, have no family history of ADHD, they have a brain injury at age 4, they keep on developing. There's a good chance that that 4-year-old is going to have ADHD after that brain injury. Other times it's 100% genetics, where you can have like a perfect childhood, perfect everything, no exposure to any kind of environmental anything, and just enough genetics to make it 100% a genetic case. Because ADHD is not, and really most of this stuff, it is not a direct etiology. In other words, like autism, ADHD, those are descriptions of behaviors. They are syndromes and not diseases in and of themselves. Okay. Another good example of that would be Alzheimer's is a disease that causes dementia. Okay. Dementia is the end product of Alzheimer's, the disease, but it's only one type, right? So it's only one type that causes dementia. There's vascular dementia, there's other types of disease processes that can result in dementia. Same thing here. ADHD is like the word dementia. There's many different things that can cause ADHD, but ADHD itself is not necessarily the same thing as it's not. It doesn't cause itself. In other words. All right. I'm going to pause us there. Y'all have any questions about any of that at all?
Well,
No questions?
what about on the exam? Can y'all hear me?
I can hear you.
The question about the potential psychological explanation for the adult onset of ADHD.
Uh-huh. I don't have the exam memorized, but so I'm going to pull it up real quick. Let's see.
So obviously not the decline of the frontal lobe beginning at age 25. Because you said that's a neural development disorder?
Yeah, I'm trying to
Or
find.
not.
As soon as I find that question, I'll be able to help you there.
Okay.
I can't find that question. Can you read it again?
Sure. It says a potential psychological explanation for the adult onset of ADHD is, and I'm
Okay.
stuck with two options.
See, let me Oh, here we go. Okay. I found it. All right. A potential psychological explanation for the adult onset of ADHD is A, the worsening of ADHD symptoms due to the individual's inability to compensate for increasing personal responsibilities. B, the decline in frontal lobe functioning beginning around age 25. C, well, it might not be the same letters. I'm just telling y'all what it is on mine.
Okay.
Because they're gonna be mixed up. But another option would be hypercoffee-anemia. And another option would be the predominantly inattentive subtype often switches to predominantly hyperactive impulsive type. All right. So that question hinges on the word psychological explanation. Excuse me. And which means that we can get rid of the potential answer, which would be the decline in frontal lobe functioning.
Right.
All right. And as it relates to, if you think about it this way, like if symptoms seem to emerge or cause enough dysfunction to cross over that threshold all of a sudden in adulthood, what might be some reasonable causes of that, right?
Yeah. What are you asking us?
Yeah, well, yeah. I'm just thinking of like more out loud.
Like stress.
Uh-huh.
Stress, overstimulation. Like you were just talking about our brains and not being able to work 40 hours or not set up to work 40 hours a week or stay up late, but maybe these symptoms are psychologically affected because of stress or lack of sleep or too much sleep or.
And so a psychological, it's not really a great question. I don't know why I put psychological explanation, but with adult onset ADHD, in most cases, they have always had ADHD. They've always had the ADHD brain. Well, actually, let me put it this way, because that way I won't give you the answer. Let's use my billionaire metaphor. So let's take let's imagine that you were a billionaire kid on an island, and you had
Mm-hmm.
no responsibilities, and you had ADHD, but you didn't have any responsibilities, so it didn't affect you. So you're never
Mm-hmm.
diagnosed. And then all of a sudden, take that billionaire kid, grows up, moves to like the mainland,
Mm-hmm.
tries to get a job for the first time, loses their job in the first week because of the symptoms of ADHD.
Mm-hmm.
That would be adult onset ADHD, right?
Yeah.
Even though they've had it their whole life. And it's adult onset primarily because of their difficulty now compensating for that level of responsibility that's required
Yeah.
as compared to what they used to have on the island. Does that make
I
sense?
I was still stuck between two answers, but I think I may got it.
Yeah. So in other words, um, adult onset ADHD, one, this is really what the question is getting at, or what I want you to know from it.
Mm-hmm.
ADHD, the pathophysiology, the neurology of ADHD, that begins in childhood. That has had to have been present in childhood. You won't always know if your client had enough symptoms to be diagnosed in childhood,
Mm-hmm.
because a lot of times the symptoms really won't emerge until adulthood, because all of a sudden they go from having all the structure of like being a child and having parents and caretakers like provide for them, to now they're expected to have this personal responsibility up here, but they don't have the executive functioning to match it, and now their symptoms emerge.
Okay. Thank you.
Uh-huh. So in other words, the worsening of ADHD symptoms due to the individual's inability to compensate for increasing personal responsibilities.
Got it. But the explanation was nice. Thank you.
Mm-hmm. I am going to move us forward here to talk about, let's see, ADHD treatment real quick. Go back there. Where was I at? There we go. And yeah, okay. ADHD treatment. Long story short is that ADHD, being a disorder of the dopamine system in the brain, means that the frontal lobe is not as active as it should be. We want the frontal lobe to be perfectly active. When you think about like the frontal lobe like an engine, like your car engine, you don't want it to idle too low, and you don't want it to idle too high, right? You kind of want the
Mhm.
perfect idling amount. With the engine of your frontal lobe, ADHD causes it to idle too low. Now, when it idles too low, that also means that it can allow your frontal lobe to let like intrusive thoughts in, causing you to be more anxious, even though it seems kind of counterintuitive. But the idling too low includes the brake pedal, not just the gas pedal. With that being said, the frontal lobe, being that it's idling too low, you cannot think hard enough to make it idle faster, right? In other words, physically, your frontal lobe is going to have a limit to how fast it can idle. ADHD reduces that idling speed, and no amount of compensating is going to let you outperform what you're neurologically capable. So sometimes that means in order to treat ADHD effectively, you have to have a medication that boosts its idling speed. Now, in most cases, that is a psychostimulant, which would be amphetamine or the amphetamine derivatives and methylphenidate. Now, there's a lot of bad information or misinformation out there about the stimulants, and they kind of have an extra bad rap right now because there's been a lot of ADHD pill mills kind of pop up online, and a shortfall in pharmacy for how much is available. But what you need to know is that the stimulants are the most effective treatment for ADHD. And it's not just me talking. I'm telling you, you can go look it up yourself. It's got over 5 decades worth of research that indicates that ADHD is most effectively treated with a psychostimulant. In adults, what that means is that in order to cope at a level that's required to meet the responsibilities of your day-to-day life, and that's variable for everybody, you might need a stimulant to get you there. For others, well, for example, if I was a billionaire on an island, I would not need to take my ADHD medication. There's no need to. But being that I'm a professor and a father and a husband and a private practice owner, yeah, my ADHD affects me functionally. And at that point, I need the medication in order to hold it all. Obviously, in my case, which is a good example, there's a subjective nature of saying, well, how much is it that you're trying to do too much versus having actual ADHD? Well, I can promise you I've had ADHD even before I try to do too much. Part of having ADHD sometimes is doing too much. But that's what I'm also saying too, is that there's always a combination of it's a system that's broken combined with also having a neurotransmitter system of dopamine that doesn't work the same way everybody else's does. Okay. I'm not saying that everybody should be on medication or stimulants for ADHD. I'm not saying that at all, because sometimes there are medical contraindications for that, which include like blood pressure problems, like too high blood pressure, or if we've got a history of anorexia, we might not want to be on a stimulant, or sometimes even anxiety and OCD. But here's what you need to remember about that, and this is important. And about 60 to 70% of people with ADHD and anxiety, about 60 to 70% of those folks, when they take a stimulant, their anxiety actually goes down. Okay. So in other words, anxiety by itself in somebody with ADHD is not a contraindication for a stimulant medication. Sometimes their anxiety is effectively treated with a stimulant. But we don't have any way of determining who's going to respond that way versus it being too ramping them up too far or idling their engine up too much. Okay. All right. It's not that I don't want to focus on the other non-medication aspects of treatment. It's just that the truth is ADHD counseling or coaching has no research to support its effectiveness. Does that mean that I never recommend it? Nope. I recommend it to everybody. I think we should always combine that with the medication, ideally, But I'm just telling you the truth of what the science shows is that the science, you're going to get the same symptom benefit or symptom reduction benefit if you give an adult with ADHD medication as compared to if you give them medication plus therapy. You're going to get the same amount of symptom reduction. I hate that too, because that suggests that therapy is not effective. Why do I still recommend it then? Well, it's because the research that is saying that is looking at one specific type of therapy, which is called cognitive behavioral therapy. And it assumes that, or the research that they did, CBT assumes that the person that you're teaching that CBT skill to, CBT skill to, is able to generalize what you're teaching them to real world situations. ADHD literally reduces that capacity. It reduces one's ability to learn something in therapy and take it from therapy at work and remember, now might be a good time for me to deep breathe. And so, of course, CBT wasn't effective at all for the most part. It's because we were expecting these people with ADHD to generalize what they're learning to everyday life, and that's not going to happen. It's also not effective, by the way, for people with frontal lobe brain injuries for the same reason. Does that mean that we just say, well, good luck, there's no hope? Nope. That means we have to do something different in order to help these folks. All right. I'm going to move us on to talk about autism and IDD. And we're not going to spend a lot of time here because we got to jump pretty quickly. And I'm going to have to wrap this up pretty quick in about 10 minutes. Because I want to talk about depression and psychosis and schizophrenia and mania. And actually, I'm going to do that because we cover autism, all that stuff in the child and adolescent class in a lot more detail anyway. That's why we have these two classes. Let's do that. So I'm jumping to week 4 PowerPoint slides, schizophrenia, psychosis, and week 3. Pull those up real quick. Actually, not week 3. I'm sorry. It's both in week 4. Depression and bipolar and schizophrenia and psychosis. All right. I'm going to start with depression and bipolar. The reason why I'm starting there instead of schizophrenia and psychosis, even though schizophrenia and psychosis comes first in the DSM-5, is that if you can understand mood and how mood is subjectively, or what causes us to feel happy versus sad, it will help you understand everything that we're talking about from here forward. And really what I want to show you, I wonder if it'll let me do like a drawing. I can do it. I'm going to pull up like a whiteboard that I can do like a drawing for y'all real quick because I want to show you this visually. This can make a lot more sense. Just gotta find my, there it is. Um, and 1 second. There. All right. Can y'all see that okay? I'm assuming y'all can. All right,
Yes.
so let me change that color. Red. I'll make fun of my drawing because this is not as easy as it looks with a mouse. So what I'm drawing here is, this is time. Like, imagine this is like a timeline of your life. Let's say you're born here and you end here, okay? Everybody on the planet, well, actually, I'm sorry, let me back up. So that's time, and this is mood. Okay? This line represents an average mood. Okay? Not happy, not sad, just average. Now, everybody on the planet has a natural cycle of mood based on the dynamics of neurotransmitters in your brain in relation to hormones in your body and seasonal and daily like fluctuations that makes your mood do this. Okay? And when you average it out, that's where you get the line from. That's what the line represents, just the average of that fluctuation. Now, here's the question. What is depression? What is mania? Right? Well, what we're declaring depression to be is an arbitrary line down here saying if your mood drops too low or crosses this threshold, then that equals depression. Okay? This is terrible drawing, but y'all following? I'm assuming you are. We're also saying if your energy level of excitement crosses this threshold, let's just go ahead and make that line like that. That or above, this or below, then that is mania. Let me ask y'all this. Can anybody tell me, how do we come up with what these lines are? Like how do we know what is too much?
I don't know.
So I gotta guess, would mania be like outside the standard deviation of what the average mood fluctuations are, and depression be outside the standard deviation on the other end?
That, I love that idea, by the way. And I really hope and wish that that would be how we would define it. Because that's a lot more scientific. And that makes a lot more sense to do it that way, other than us just kind of eyeballing it like the DSM-5 does.
Is it based on the amount of time? Like all the other disorders are based on time?
So it does matter.
Or
It does
duration.
matter how long the duration is, but again, like as far as, well, I guess the question is why are we setting the line here and not here? Why not set it up here in severity level? Why not make it here for depression? And the answer to that, just so you know, because it is hard to answer, it's kind of a trick question. It's arbitrary. They have, the APA has a designated like cutoff for how many symptoms you've got to have and for how long. And if you don't meet that cutoff, if you're only here, but not here, then you don't have mania. Well, you and I both can look at this and say, well, but you got some. Does that make sense?
Yeah. I think the hesitation for, I think us as beginning therapists is, okay, is this just situational or is this more long-term? And even situational may need, the client may need medication, or whatnot. But, when does it become more than just situational and it becomes more long-term? Does that make sense?
Sure. And so here's the thing is that the answer to that is everything is situational and everything matters in the long term. What that means is that if you encounter somebody who is manic, let's say it's the very first patient you've ever seen, it's your first patient ever as a counselor in training. Third session in, they come in and they meet the definition of mania. They got a flight of ideas. Their thoughts are racing. They are speaking real fast. They're not making a lot of sense. They're extremely euphoric or agitated, right? The question is like, oh, okay, well, is this a short-term or situational thing, or is this a long-term thing? Well, the answer is it's both. Because it might be that they are intoxicated on methamphetamine. And it wouldn't matter who you are. If you're intoxicated on methamphetamine, you're going to come in looking like that. That's a situational thing, right? And that would be a substance-induced mania. But the other side of this equation is that the fact that they are manic, and it might be the first time they've ever been manic, but the fact that they are manic, it means that that is now more likely to happen again down the road. So it is a long-term thing. And if you have one manic episode, that is all that's required to make a diagnosis of bipolar, by the way. One manic or hypomanic episode. So, in other words, when your brain experiences, well, let me see if I can put it this way. I'm going to erase some of this stuff real quick. I'm going to redraw everything, parts of it. When your brain experiences a mood for a long enough period of time, here's your mood over time. If we shift this curvy line up, right? Meaning that if we did this, that also means that this average here, right, is going to go up. Everybody agree? I'm assuming that's
I didn't follow that. I don't understand why that would.
all right. So think about it this way.
The average shift just because one individual shift.
Right, and I'll explain it better here. So this line right here represents this average line is average for this person here.
Okay, got it. Then I do understand. Thank you.
So it's not the average for the general population. This is the average. If you were to average out this person's fluctuations, that's what that line represents.
Yes, sir. Thank you.
Yep. If we shift up there, even just the top point, right? So even if, let me do this. If we cause this person to have mania, right? And we keep the same lows, but we cause this person to have mania. Their average, which is highlighted by this right here, this line goes up. In other words, their average becomes more manic. That's their baseline. So what I'm trying to show you is that when your brain experiences any fluctuation from the average, and it doesn't have to be just mania, it could also be depression. But the longer it stays in the lows and the longer it stays in the highs, the more it's going to shift up and down your average, causing you to be more likely to experience abnormal amounts of lows or highs. Y'all follow me on that?
Yes.
Yes.
Awesome. And that's important as it relates to long-term implications, because, and that's why I'm bringing this up, because when you said earlier, we don't know if it's situational or like a long-term thing. Well, it's always a long-term thing because we're identifying at least one episode, we're observing at least one episode while we're meeting with that client that is outside of their average, substantially outside of their average, which means that even if it never happens again, this one episode has now shifted and increased the probability of it happening again. That's how the brain works, by the way. The brain works in relation to adapting and learning and trying to be average. Your brain's always trying to go for the average. Psychopathology and depression and bipolar mania occurs when the brain stays too long in a low, which then results in a shifting down of that person's average, or too long in a high, which causes them to shift upwards in their own average. Now I'm going to complicate this a bit. See, draw another line over here. Now I'm going to make this the average for the world population. Okay. Whereas a while ago, I was saying that line represents the average for that one individual. Now let's make it the world population. Okay. What I was saying earlier is that we have made distinctions, or the DSM-5 says, hey, when you cross this threshold, or when you cross this threshold, that's mania and that's depression. My question earlier too was, well, where in the world, how do we define what this is? Because what the DSM-5 is saying is, well, this isn't depression. That's not mania, right? What do y'all think? How do we
I guess something.
define this? How
Go
do we
ahead.
define that? Sorry to interrupt. What was your question?
Oh, no problem. I guess that's where I'm confused because I do know of someone I work with, and they were diagnosed for years and treated with medication for, I think, like bipolar, but it was like manic depression or vice versa, and it changed their entire career. So, like, how do we avoid? Because if it was just like a moment, I know you said if it happened once, then it can basically happen, later. I guess in the future. I guess how do we diagnose a person? Because the wrong medication can change their entire life, or
Oh,
if our
absolutely.
treatment plan doesn't match. Sorry.
Absolutely. And that's the importance of diagnostic accuracy, right? So like I'm not going to make a diagnosis of bipolar 1 disorder if I have a patient that I've just met who appears to be manic. I'm not going to make it that diagnosis because I don't know if this is substance induced. I don't know if we've got a liver like encephalitis happening where there's, literally like the blood's not getting filtered the way it should. I don't know if they just had a brain injury or if they're having seizures or they just had a super traumatic episode happen yesterday, right? And
Right.
so, but I do know that they are acting manic, and as it relates to their future risk for developing bipolar 1 disorder, it is now increased. Even if it's not a true bipolar, it's caused by something else. Now, to go back to what you were saying with like the wrong medications and things like that, absolutely, there are. If we jump to the conclusion that this person has bipolar and we treat them, let's say, with lithium or an antipsychotic, well, first of all, you need to know that it's a lot more complicated than what I'm about to say because mania, in most cases, should be treated with a mood stabilizer no matter what is causing it. In the same way that a seizure should be treated with seizure medication, right? If somebody's having a seizure, it doesn't matter what's causing that seizure. They need to take seizure medication to stop the seizure. It's the same thing with mania. If somebody's having a manic symptoms, it doesn't matter what's causing it necessarily as much as it is, we got to stop those manic symptoms. Now, the downside is that some of the medications used to stop mania and seizures for that matter have long-term negative side effects that sometimes are very unpredictable. In other words, we don't know who is going to experience some very traumatic and tragic side effects. And so, I'm not sure if I'm answering your question, but my point there is that your brain, we want, as clinicians, we don't want our clients to experience two many or too long of symptoms in the peaks and the valleys, because the longer they stay there, the more likely they're going to go back there. Okay. What that means as a counselor is that if you're working with an adult who's never had any treatment their entire life, use one more drawing, and I promise I'll be done drawing after this. And you finally see them at this point here in their life, okay? But before they saw you for counseling, they have been here, right? And now you're going to start counseling with them. Well, I can tell you is that counseling, the prognosis for that person, for them to benefit to where they wouldn't have a diagnosis of bipolar or whatever, or depression, the prognosis isn't as good. I'm not saying it's impossible, but it's not as good as somebody who here you're doing counseling and who's only ever had one depressive episode their entire life, right?
Okay.
Because for this person, their brain has had repeated events of depression and mania, and it's had it so often that it's going to take moving the world, moving a mountain, to stop this pattern from happening anymore and to help them get back to normal. For this person, it's not going to take nearly as much intervention to stop that from happening to help them get back to normal. Does that make sense?
That makes sense.
Okay. That's why it's
It's
important for us
12:47, Dr.
Yeah, I know. I'm going to have to wrap
Just
this up.
cognizant of your time.
Hey, thank you. The last thing I'll say is that's why it's important for us to make sure we're intervening as soon as possible, not just with medication, but medication if needed, but counseling especially, because if we catch this stuff early, the opposite's also true. If somebody's going along in life and all of a sudden they dip too low, if we start counseling right here before they can have a lot of time spent there, and we help them get back to normal, well, guess what? It doesn't disrupt their average. That's why we do what we do. And here's the other cool part. When we do this and we prevent them from spiraling one way or the other over time, we are literally changing their genetics. I'd say they are changing their genetics and are now less likely to pass on a predisposition for depression or the predisposition for bipolar. Y'all follow me on that? And that's the epigenetics.
Yes.
That's the coolest thing ever. In other words, what we're doing isn't just therapy for that one individual. We might be doing therapy for generations of individuals, of their family. That's cool. Okay. I am going to pause this right there, but we do not have class tomorrow. Tomorrow's Easter. I will be flying, unfortunately. We will have class the following Sunday. We will jump back into psychosis and schizophrenia and kind of rehash some of the bipolar stuff, but we will also start that transition into anxiety disorders and moving forward from there. But I really, really, really wanted to get to this today because outside of everything else, you need to know that there's a normal fluctuation to everybody's mood. When it gets too high, that is arbitrarily defined as mania or hypomania. When it gets too low, that's arbitrarily defined as major depressive disorder or a depressive episode, or dysthymia. And if we stay in those too high or too low, the longer we stay in those episodes and the more often those episodes happen, the more those become our average, which means that it becomes harder for us to not experience those episodes, which in turn means that we've got to help identify these things sooner and faster when they are happening and younger, so that through that intervention, we can prevent it from happening, from, or at least reduce the risk of experiencing another episode like that from there forth. Okay. Does that mean that there's no hope for the 80-year-old who's never had any treatment? It's the first time we've ever had treatment for the depression? No. They definitely still have hope. You can help them improve their quality of life. As it relates to helping much in preventing recurring depressive episodes, probably not a lot. But in the here and now, you can help. You can help them develop skills for coping with it and identifying it sooner, so that it's not as it doesn't cause as much dysfunction. Yeah. All right. Like I said, we will jump back into psychosis next time. It won't be tomorrow. It'll be the week after that, which is, I can't remember what day that is. It's not the 9th. It is the 16th. Yep. That's when our next class is. And then I have this recorded and I will be putting this on Moodle. And then in the meantime, please message me if you have any questions. All right. Y'all have a wonderful Easter weekend, and we'll see you in a few weeks.
All right,
Thank you.
I'll see you in 30 minutes at child development.
Oh yeah. Yep, we'll see you then.
Bye.
See you later.
Thank you. Happy Easter.
Absolutely. Happy Easter.